All right, let's get started. So welcome everybody, and thank you so much for joining us here today. My name is Rochelle. I am a product manager here at Clean Slate UV. Here at Clean Slate UV, we're on a mission to create the next generation of intelligent sanitization solutions for a mobile-first world. We're leaders in device hygiene and remain dedicated to scientific research and expertise. Today, we'll be actually having our main speaker, Cameron Thomas, talk about his experiences and lessons learned during the COVID-19 pandemic. Cameron has been in infection prevention and control, or IPAC, for 5 years. His career started as a volunteer as a hygiene auditor at St. Michael's Hospital. Later on, Cameron became infection control practitioner at St. Joseph's Hospital and was the COVID-19 lead there. This year, Cameron actually joined the executive committee for the GTA chapter of IPAC Canada, whereby he continues to share experiences, do research, and support the IPAC community. So for today's agenda, we'll be having a presentation by Cameron and for 20-25 minutes, and then at the end, we'll leave around 5 to 10 minutes for questions. So Cameron, I am giving the control to you. Hopefully, let me know if it works on your end.
All right. Thank you, Rochelle. And I'd like to thank Clean Slate for organizing this. I hope everyone can hear me. Rochelle, maybe a quick thumbs up.
Yes, you're good.
Okay. So yeah, thank you very much for organizing this, and I appreciate everyone coming to join today to have a quick chat about IPAC. Anyone who knows me knows I probably tried to cram too much into a small amount of time here. So I'll try and move quickly so that we can definitely get to some questions at the end of it. So basically, we're going to have the brief intro to COVID you've ever seen, just because at this point, I would imagine everyone is more familiar than they ever imagined they would be with a virus. We'll talk a little bit about some of the challenges that we encountered during the pandemic, and that includes supply shortages, some of the creative solutions that came up to deal with those, and then we'll have a special section just about hand hygiene that kind of talks about the importance overall, as well as talking about some of the observations that we had during the pandemic that might be a little bit surprising. So basically, SARS-CoV-2, as you're aware, first started popping up at the end of 2019. It is a novel virus of the coronavirus family. Coronaviruses can cause simple colds, but they also are the family that includes viruses such as MERS-CoV or the previous SARS-CoV. So it is a lot that we needed to learn about it as it first began to emerge. Now, the standard IPAC response to a novel infection is to treat it, or novel viral infection is to treat it as a potential airborne spread, and that's just using the precautionary principle. So basically saying, start at the highest level of additional precautions possible, and then as more information comes to light, then we can kind of scale it down to be more appropriate. So it's just ensuring that we are protecting everyone at the highest level that we can until we have that information to really say what's going on. So in this case, eventually, as we all know, we determined that the primary route of transmission was direct person-to-person contact via the droplets, and that includes then some possibility of transmission through indirect contact as well, so surfaces. And there were findings that in favorable environments, it can also spread via aerosols, which led to a lot of confusion about airborne transmission versus aerosols, but that's a whole separate discussion on its own. I'd love to have that sometime if people want to learn more about exactly what the distinction between those is, but I think it's still important just to point out that it really is the possibility of aerosol transmission based on aerosol generating medical procedures, and that it is not considered to be a true airborne spread. Now, information came very, very quickly, and so one of the biggest challenges that we encountered was the consistent messaging, which I'll talk about a little bit later on. Before that, we'll talk about pandemic preparedness, which I think is something that every facility and everyone with an IPAC team has been working on, but there are challenges with looking at that because it's something of an abstract idea a lot of the time. We'll talk about supply shortages, like I mentioned, and then the hand hygiene part, which I think is very important. So pandemic preparedness, teams are always making these plans for the pandemic. They're aware that, we kind of go in these cycles where a novel virus is going to crop up, and we need to have plans in place so that we can ensure that we are protecting all of our staff, visitors, patients, and that we're prepared for everything that can come up. I think one of the real challenges is that it's difficult to get people motivated when it is an abstract idea. So in between pandemics, getting people to prioritize working on something that really is a gigantic planning process, because it involves basically every stakeholder in the hospital, and you need to consider just so many different factors in terms of how you're going to be triaging, what you need to do with certain areas, ensuring that you have adequate stocks and supplies. All of those factors need to come together, and I think it requires an absurd amount of work, and the actual pandemic plans that most facilities come up with are giant documents that then revisions require an awful lot of time. And when there isn't an imminent threat, then I think getting people to prioritize that can be really challenging. Now, obviously, with our current state, I think we're going to find a lot of people are going to be quite excited to work on these at the end of COVID, but I think at the same time, there's going to be that slight sigh of relief where people then want to think, okay, we need to catch up on what we maybe put off during the pandemic. And so it may get held off a little bit and then relegated. So I hope that people remain vigilant and work on their pandemic plans after COVID, just to ensure that for the next time that we're in a situation like this, which is inevitable, that everyone is prepared and hopefully has learned some lessons from this experience. I think that consistent messaging is something that we ran into as a real challenge throughout the pandemic. Now, IPAC have always been aware that we need to be consistent in the way that we communicate with staff, because any inconsistency, it can be seen as a weak recommendation. It kind of undermines the whole idea that we are really experts in what it is that we're talking about. So what I always think about is that before the pandemic, you could talk to IPAC teams at various settings over the course of weeks and ask each one of those separate teams the same question and get basically the same answer from almost all of them. But during the pandemic, you could ask the same team a question in the morning and ask them the same question in the afternoon, and you might get a totally different answer from that same individual, just because the information was evolving so quickly. And I think that what that did was there were some staff who viewed that as being something suggesting that IPAC weren't really aware of what was going on, or that the recommendations were flimsy. But I think what it was just, and what it says on this slide is very important, which is that transparency is important, but also that science is always evolving, and we need to accept that. We need to work with it. We need to take what the newest information is, the most relevant information, and put that to use for us. One of the major challenges that came up otherwise was the supply shortages. And I think that we're all aware of kind of some of those were. So obviously there were shortages with various types of masks, in particular N95 respirators. Some disinfectants were in short supply as well. I think one thing though, it was difficult to come up with any kind of good news during the pandemic, especially in the first 2 waves. I think there was just so much information coming at everyone. So what I tried to frame as being good news to people was that the one good thing that we can take away is that it is an enveloped virus, and so it's actually very, very easy to kill on surfaces. So all healthcare approved disinfectants in Canada are effective against COVID, and that just means that even though we were seeing some of those supply shortages with things like, in particular, bleach-based cleaning products, we still had other alternatives that were going to work for COVID. So it just meant that we needed to think a bit about prioritizing some of those other disinfectants for organisms that are maybe more difficult to kill, and in particular something like C. difficile. So I think that was something where we just needed to kind of revise, because some facilities had tried to use more of a universal approach with bleach, and instead you maybe needed to target it specifically based on risk. Now, in terms of the mask use, obviously it wasn't that far into the pandemic that we began talking about universal masking within hospitals. And the reason for that was very simple. It was that more so than with many other viruses, we were seeing that asymptomatic presentations of the virus and people who were asymptomatic carriers who had the potential to transmit. And so because of that, it meant that we couldn't use our usual triaging strategy of looking for those signs and symptoms. We were still asking the same questions when a patient was admitted or coming in through the emerge in particular. But then beyond just looking at those signs and symptoms, we knew that there was the possibility that for the 24, 48 hours preceding symptoms, or in some cases, patients wouldn't develop symptoms at all, that the patient could still be a risk for transmission. So as a consequence, we moved to universal masking for all staff, and in some facilities they went beyond that. But basically, everyone who was caring for patients began wearing masks at all times. And then in most facilities, it was also including anyone who was patient-facing or anyone who was working within the facility. Now, with that came other challenges, in particular because we had previously, and this comes back to the messaging part, said that wearing masks for prolonged periods of time was bad. That was the IPAC recommendation. We didn't want you to wear a mask all of the time because it's difficult not to touch it. It may not be on properly. If it becomes moist or damaged or soiled, then you should be replacing it. So all of those factors can make wearing a mask for a prolonged period of time more challenging, not to mention just the discomfort that comes with it. So what we had to do was provide significant education talking about how to properly put on a mask, how to recognize when you should be taking off and discarding your mask, as well as just that being conscious and aware of how much you touch your mask in your face at any given time throughout the day. And I think that that's one of the bigger challenges that frontline staff saw. And I'm not going to lie, I was in presentations with senior leadership who were talking about the importance of wearing a mask and who spent the whole time touching their mask and adjusting it without realizing it, because it's natural. All of us kind of do that. So it was kind of asking people to maybe not call each other out on it, but develop a system so that you could remind each other that, like, oh, like, you're not aware of this, but you are putting yourself at risk because you just reached up and adjusted your mask again. Beyond that, we also looked at reusing masks. Ultimately, the decision was that for frontline staff, reusing masks carried too much risk. But in the cases of like non-patient facing individuals who are working in the hospital, because they were wearing the mask predominantly as a method of source control, there was less risk that the front of the mask would be contaminated with someone else's respiratory droplets. And so there were strategies in place for how you could remove and safely store and then reuse that mask. But because that was rolled out at the same time, there was also confusion among frontline staff about why they couldn't reuse their mask. And we had to do significant education again to show that, you know, we've explored all of these options for how you could properly remove it and store it, but I think there's still just too much risk because of the potential for, say, the strings that actually hold the mask on getting contaminated in the process of removal or storage, that then in putting it back on, you may think that you're putting it on in a safe way, but it could still be putting you at risk. And then obviously just another challenge is in prolonged use, people are going to need to have a drink of water, or they're going to have an itch or something, right? And so you need to come up with ways of reminding staff to think about where the risk comes for themselves, because you can't necessarily just standardize it the way you would the 4 or 5 moments of hand hygiene to say every time this, you need to do that. Instead, just trying to get them think more broadly about where the risks are and how to prevent that for themselves. With the N95 respirators, obviously very early on, there was a lot of challenges and there was a lot of confusion because of this aerosol potential spread and the perception that that could then be airborne. So N95 use skyrocketed and inventory was dropping very quickly. So we needed to really try and prioritize and give a lot of messaging to staff about prioritizing use of N95s only in situations where it was indicated, which is to say not necessarily wearing an N95 where it's unnecessary from all of the recommendations that we had at the time. And I think that because of the perception of staff, some felt that we were making this recommendation purely to say, we don't need to use it, we need to cut our supply, and maybe that was cost related, but that was absolutely not the case. We were just trying to ensure that we didn't end up in a position where someone 3 weeks later was going to be doing an actual, like intubating a patient, a very high risk situation as an HEMP, and didn't have access to an N95, and would that therefore be at risk because someone else had worn an N95 in a situation that it was unnecessary. So fortunately for us, we also looked at many other solutions. I think one of the great things about a situation like any emergency or the pandemic is that we really get to see the creativity of everyone come together to face one common threat. So in this case, we were looking at alternatives like elastomeric half-face respirators, which had their own challenges within it, and some really creative solutions in terms of how to mitigate some of those risks. As well, there was a lot of consideration about disinfecting and reusing N95s. There were various ways of trying to do that. Some facilities got very, very far into that planning, but ultimately, at least in Ontario, we were never in the situation where the Ministry of Health recommended that we actually move forward and implement those strategies. So it was mostly just collecting all of the used masks and continuing to trial some of those processes and ensure that we had all of the processes in place so that we could then if needed, roll it out somewhat quickly and effectively. And I think that, again, one of the big problems there is perception. So a lot of people felt that they didn't want to wear a mask that someone else had been wearing before because they thought it would just inherently be gross. But I think that what we were trying to emphasize was these masks had been disinfected. So realistically, there's no risk within that, but it's still just kind of that ick factor that we couldn't get past for some people. Again, in terms of surfaces, I pretty much covered all of this already, I think. So just talking about one of the really nice things about it was that everyone was much more invested in IPAC, I think, during the pandemic than maybe some individuals were before. I think everyone's aware of the importance of IPAC, but it's often viewed as kind of an abstract idea. But during the pandemic, people were really looking at what are some other things that could be influencing risk and transmission. So they were talking to us about surfaces that maybe aren't cleaned as frequently or as effectively as they should be, or they're maybe not using the right disinfectant on it, or there's a piece of equipment that only gets cleaned once a day or something like that. Just things that otherwise we weren't aware of. So we had really, really good feedback from people, and I think that that really improved some of our cleaning practices throughout the pandemic. Now, in terms of hand hygiene, I just wanted to point out, because I know that we have international members potentially as well on this webinar. In Ontario, we use the 4 moments of hand hygiene, and that's a little bit different from the World Health Organization's 5 moments of hand hygiene. I just wanted to point out that they're actually the same. So if you look at specifically the moments 4 and 5 in the World Health Organization, and you look at moment 4 in the IPAC document there, you'll see that all it is that moment 4 in Canada includes moment 4 and 5. So we're saying that we're treating the patient environment and the patient as being the same. When you're leaving the patient environment, if you only touch the patient, you only touch the patient environment, or you touched either, clean your hands before you touch whatever it is that you're going to touch next. And I think hopefully everyone here is familiar with just how significant hand hygiene is. It's one of the best methods of actually preventing transmission, not only of COVID, but of many other organisms that we see in hospital that we're really concerned about healthcare associated infections with. So it's just, I think what I try and really emphasize to frontline staff with hand hygiene in particular is, yes, the 4 moments or 5 moments are key, and they are a great starting point. But I think beyond just memorizing what those moments are and trying to do them specifically at those times, is to think about where the risk is. Think about what those moments represent. And I think basically all it is that truthfully, IPAC is one of the most common sense professions in the world. It's common sense that's backed by science and common sense that's backed by data. And all of those things are based on the most recent science that proves that those theories actually work. But when you think about it, every one of our recommendations is pretty sensible, right? So if you think about why it is that you're doing what you're doing, you'll understand where the risk comes from, and you'll be much more involved with trying to make the decision for how to prevent that. So for hand hygiene, just thinking about what did I touch last? What could be on that surface, and what am I touching next? And for most people, it's very intuitive when you actually just think about it that way, as opposed to thinking, oh, well, was I supposed to clean it before I touch the patient environment or the patient? And the reality is it's before anything that's within that space, right? But then I think it's also a good reminder for people then to think in particular about moment 2 and understanding that, there's flora that exists on a patient's body that belongs on the outside of their body. But then if you're manipulating, say, an open wound and you haven't cleaned your hands, you're at risk of taking some organism that was living on their skin, introducing it into an aseptic area, which then could lead to an infection, right? So it's thinking again, what did I touch last? What could be on that? What am I touching next? And does that next thing, is it already at risk of being contaminated? Do I need to clean something else, right? And just each one of those steps then makes a bit more sense when you think about what it is you're doing. Instead of thinking, IPAC wants me to clean this machine every time I use it, you're thinking, I use this machine, these parts of it came into contact with the patient or the patient environment, so I need to clean those surfaces before it's used by someone else. Now, in terms of hand hygiene during the pandemic, I think this is probably the thing that most people would be most surprised by. I would imagine that most people would expect that hand hygiene rates increased throughout the pandemic. And for the very beginning, that was true. So what we found, and this information is actually coming from a study that was conducted in Marseille, but it reflects a lot of the same information that we saw locally within Ontario. And I can confirm that through my own experience at a couple of hospitals, as well as what I saw from some of my colleagues in talking about what was happening with their hand hygiene rates. So basically what it was With the first wave of the pandemic, hand hygiene rates increased quite significantly in many cases, in particular in, say, the ICU or the ED, because they might have been seeing more of these COVID patients and been more aware of what some of the risk was in terms of what was coming. But then basically, as soon as the first lockdown ended and some of the restrictions in the community were eased, hand hygiene rates dropped significantly. Not necessarily back to the baseline, but they did drop significantly from where they had hit that peak. Then the second wave began and hand hygiene predictably went up again, but it didn't reach the same level that it had peaked at during the first wave. And then restrictions eased, second wave ended, and it dropped back down to about the baseline again. And that third wave hit up again. So basically it was like it increased quite a bit on the first, dropped down, up a little bit. So it's tapering each time and it's kind of evening out. So if it continued like that, eventually you would just remain at the baseline, I think, and stop seeing any of those peaks. And basically what this indicated to me was that the pandemic acted like a lot of hand hygiene strategies implemented by IPAC teams previously to improve hand hygiene. And those could be as simple as like putting up posters or creating more awareness on the unit, which is to say, at first, acutely, the numbers increase, but sustainability is the real challenge. And I think that that's what we've been finding throughout working in IPAC in my career, is that you can increase compliance for hand hygiene or just about anything from an IPAC standpoint in the short term quite relatively easily. But it's getting people to really buy into it and participate so that it is sustained that is the real challenge. And that's really what we're struggling with at this time. Now, the other thing that I wanted to point out in this data set and what we found throughout the pandemic was that we also really significantly saw the disparity between moment 4 and moment 1 continued throughout the pandemic, which is to say that prior to the pandemic, we always found that moment 4 was quite a bit higher than moment 1. And I think that logically that makes some sense because it is people are more likely to clean their hands looking after themselves, right? It's that they're at that point, moment 4 is protecting yourself from the patient that you just cared for. Whereas moment 1, they may think that their hands are still clean or I haven't touched anything particularly dirty. And so it's not that same internal motivation. So what we found was the same thing throughout the pandemic, which is to say that moment 1 did improve, but certainly moment 4 improved significantly more than moment 1 did throughout the pandemic, and that moment 4 continued to drop down in the same way as moment 1. But it's just once again a little bit. That's the real challenge that we're finding, is getting people to clean their hands and see the importance of going into the patient room with clean hands. And I think that one way to try and remind them of that is even just perceptually, right? I mean, when you go into a patient's room, if the first thing they see you do is to clean your hands, and they know that you're caring for them in a whole fashion. Whereas if they have to ask you for it, then the whole dynamic between patient and healthcare provider is so challenging that I think most patients wouldn't necessarily feel comfortable saying it, but they may feel immediately like, oh, why didn't you clean your hands? I don't know where you're coming from or what you did. And then here's just some basic information that we brought in from the World Health Organization, just reminders about some of the significant impacts that IPAC interventions can have. So in particular, that effective IPAC programs can have more than a 30% reduction in HAIs, which is truly incredible, and that information is backed by the World Health Organization. And in particular, that improving hand hygiene practices can reduce transmission by up to 50%. And I think one of the real challenges there is obviously trying to determine how it is you're going to observe and track hand hygiene compliance and improvements, because there are so many different ways to do it and each has their own benefits and pitfalls. But I think really it's about that continuity of improvement. So it's looking at how you did compared to your previous. And so as long as your observation strategies are the same, then I think you're in a good position. Otherwise, big things that are important are obviously that the teams, frontline teams, require more support from IPAC. And that's during pandemic times and outside of pandemic times. I think just we need to be a bigger presence and provide more interaction with those frontline workers. IPAC requires more support in terms of resources and personnel. I think that that's the only way that we're going to be able to provide that education and that support to those frontline staff, is to have more people involved in IPAC, to expand the teams and to maybe look at some of the different methods of surveillance and data tracking that we can use. The collaborations that occurred during the pandemic were fantastic. They really brought to light some things that we knew were issues that maybe we hadn't been able to get that engagement from frontline staff on, as well as discovering things that we had no idea were a problem because we just never observed that specific process. And I think just the main thing was that individuals were much more receptive to the recommendations because they were really living in a world where they were understanding and really thinking about the IPAC repercussions. So I feel I went a little bit long. I'm hoping that some of you will stick around for a little bit to have some questions and just a quick discussion about the presentation. I'd really like to thank you for your patience.
Yeah, no, that was actually really great. Thank you so much, Cameron. It was great to learn about the challenges and the things that you faced as an IPAC specialist, especially during COVID-19. We actually do have a couple of questions here. The first one is actually pertaining to the pandemic. So what are some things to look out for with infection prevention now that we've seen its value during the pandemic?
Well, I think really it's about implementing everything that we've known all along. And I think that that's the case from the IPAC team. Like we certainly have things that we've been trying to bring forward. I think one example of that would be that a lot of people seem to think that this HEMP business with COVID was a brand new idea, that was something that had never been considered before. But realistically, IPAC teams have been bringing this up during flu season every year because there is the potential for transmission of influenza during an aerosol generating medical procedure. And so we would make the recommendation that individuals wear N95 respirators when performing those for patients who are at risk. But I think it was always viewed as overkill because people are more comfortable and more familiar with the flu. Whereas now COVID is novel, it's scary, it has people's attention. So I think what we need to do is take everything that everyone has learned from the pandemic and being involved in the pandemic and just recognize that we need to be using those for all of these organisms that we're otherwise familiar with, like the MRSA that we're seeing on a daily basis, or VRE, right? And thinking about how is it that we can actually protect ourselves and our patients, because I think we know how to do it properly, but I think we just need to get people to think about those organisms in the same way that they do COVID. And I think that that's just trying to reiterate that, like, being familiar with something doesn't mean we should be accepting.
Great. No, that's really great. The next question we have is, it's actually pertains to sustainability of hand hygiene, but how can we best sustain prolonged hand hygiene protocols?
That is the billion-dollar question. I think if I had an answer for that, I would be on the private island that I have purchased, just enjoying myself. Because realistically, like there's so much research being conducted by behaviorists, by IPAC individuals. There's just so many elements to consider when trying to figure out how to make these suggestions sustainable. Now, one idea that I've heard from an individual that I worked with in the past, and I won't name them because it's meant as a joke, was like shock collars, just so that every time that a moment was missed, there was an immediate reminder that you need to clean your hands. I think that the idea there is obviously not shock collars, but I think immediate feedback is one of the most important things, so that people can actually recognize that they have missed a moment. Because I think one of the biggest problems we have with the information that we provide in terms of hand hygiene compliance is that it is so broad and based on a unit that everyone just says, well, that's not me. That's not how I do it. I clean my hands 100% of the time. It must be someone else on the unit who's missing moments, who's ruining it for me. When the truth is, all of us miss opportunities. You need to really understand where the moments are. And I think that a lot of people understand fundamentally what the 4 or 5 moments are, but they're not necessarily incorporating that into their daily practice. And that makes sense because there's so many moments and it moves so quickly and there's so many other priorities throughout the day. So I think that's why we need to come up with a way of having that immediate feedback so that people can recognize personally where their missed opportunities are. So I think people want to improve. They just also don't necessarily believe that they're at the level that is being presented by others.
Right. No, that's really good. And I know hand hygiene, like you showed, is very challenging, definitely with sustainability. All right, well, that is time. So I do thank you for everybody for, attending and asking questions. Thank you again, Cameron, for participating in our webinar. We learned a lot of great things, especially about your experiences and hand hygiene. So thank you everybody for attending, and I hope everybody has a great day.
Thank you, Michelle. Thank you, everyone.